Welcome to the third session of the focus of care ultrasound, and it will be about RDS, TTN, and some other problems. So the objective, we will speak about air bronchogram, and then we'll categorize the RDS according to the ultrasound finding, and we'll talk about TTN and other problem that encountered during the use of lung ultrasound. So what is air bronchogram? These are artifacts represent the thickening of the bronchi. And usually the bronchi appear when the surrounding tissue become diseased due to blood exudate, aspiration, edema, or when the air bronchi become inflated with air. How they appear? They appear like A-lines, but they are short, they are different sizes, and they are of different directions. They are not horizontal like A-lines. So when they are static, that means they are always present. It gives the impression that the bronchi is collapsed. While when they are due to hyperinflation of the bronchi due to trapped air, they become dynamic, or they disappear and appear with the respiratory cycle. Now, when we categorize RDS, and as we know, RDS is kind of collapse of alveoli and sometimes the bronchi due to deficiency of surfactant that lead to loss of surface tension and collapse. And the RDS depend on the level of deficiency of surfactant or spectrum from mild, maybe normal finding, to the most severe one. So in RDS type 1, there is normal finding. In RDS type 2, there is some abnormal finding, but there is normal A lines, there is normal B lines, and there is normal lung. So as we can see here in the RDS type 2, there is some pleural thickening, and there is some coarse feature at the subpleural lung, represent consolidation, and there is some air bronchogram. And they present as bright lines or spots or irregular direction lines just at the subpleural area. While you can see there is some A lines and there is B lines that they do not reach to the end of the picture. When become RDS grade 3, there is more consolidation, and there is bronchogram at the subpleural area become more variable, and the B lines become more prominent, become more close to each other, and they reach the end of the picture, and we can see absence of A lines. And there is sometimes some pleural effusion and local area of consolidations. When it becomes type 4, There is significant consolidation. As we can see, the air bronchogram has gone down. They become more coarse and they become more frequent, increased area of consolidations that interfere with the appearance of the V-lines with the presence of some pleural effusion. Another type of grade 5 RDS, and you can see the V-lines extend to the end of the picture, absence of the A-lines, and increased echogenicity. And you can see here somewhat less affected area where the B-line become less intense and appearance of some A-lines. So there is severe RDS and segment with mild RDS. TTN, almost like a severe RDS with increased echogenicity, and the lung appear white-like, and almost always resemble severe RDS, but the difference would be the history. Type of TNN, usually pathognomonic, or we call it double lung point, where we can see abnormal pleural line with B lines that coalesce and severe and reach to the end of the picture. So interstitial syndromes or presence of fluid in an area where the B lines does not reach to the end of the picture with the presence of some A lines, and that's what we call it double lung point, and that's a pathognomonic of TTN. Another lung point, interstitial syndrome with some A lines and the B lines do not reach to the end of the picture. The sensitivity of this double lung point is about 77%, but they are very specific. Double lung point, B line, reach to the end of the picture, does not reach to the end of the picture, presence of A lines. Interstitial edema on the right, there is again B line, there is couple of air bronchogram, increased echogeny on subpleural area with some pleural effusion. These are different type of interstitial edema versus alveolar edema. You can see here normal lung. The B line does not reach to the end, the presence of frequent A lines. And here you can see the interstitial edema, the mild one, the B line reached to the end of the picture, and the A lines start to decrease in the number and appearance of some air bronchogram. Here, as you can see, air interstitial edema, whereas the line reach, the B lines reach to the end of the picture, and they start to coalesce with subpleural increased echogenicity. And here you can see that area of consolidation. While this subpleural consolidation is more severe, you can see multiple of air, and they are coarse and they are increased in echogenicity. When we're looking to superficial pleural effusion, we should use the superficial probe or the high frequency flat probe or the hockey stick, and always the marker either to the right side or to the pointed to the head. And usually, because there is no air in pleural effusion, it appears as black area. And because there is no air and there is no reverberation of the pleural, parieto-pleural interface, then there will be no mirror image. And also, we will see if we use a deeper tissue probe, we will see the vertebrae. As we know, the pleural effusion either exudate, transudate, or homeothorax or hemothorax. And also we can determine by the ultrasound the size of the effusion. You can see here there is a black area filled with fluid, and there is some septi, and you can see the spinal vertebrae. So this is nothing more than fluid filled with, this looks like a clear fluid, there is no debris inside. Another area of smaller size, but you can see also there is a black area, there is fluid here, and there is septi, and the septated, so probably might be either exudate or some sort of abscess or infected pleural effusion. Another type of pleural effusion that's around the mass. You can see the liver, you cannot see a mirror image, you can see a mass, you can see some V lines of lung, and you can see here some fluid. How we diagnose pneumonia on ultrasound? We see consolidation, so loss of A lines. There's also no so there is no B lines, there is no A lines. And because of consolidation, the ultrasound will reach to the deeper tissue, so we might see the vertebral or spinal sign. Some of the lung tissue will appear hypoechoic, but we will see wedge-shaped areas which is poorly defined, and we might see an air bronchogram. Air bronchogram usually in contrast with the lung tissue hypoechoic area as a hyperechoic horizontal lines, but they are not parallel, and usually they only present with the in the consolidated area. And because sometimes there is air trapping, they might change in size during respiratory cycle. And sometimes in severe cases, if you put Doppler, you'll see some Doppler changes, but as you see, there is no vessels, so what we call hepatization of the lung in severe cases. We also see massive lung edema. We can see lobar pneumonia. We can see same finding in contusion and atelectasis. Here is a picture of pneumonia. You can see there is hypoechoic area of the lung tissue, and there is hyperechoic different size air bronchogram, and surrounded by normal tissue, and you can see here some B lines and some A lines. You can see here there is hypoechoic area with hyperechoic lung tissue with hyperechoic air bronchogram surrounded by some fluid. So there is a pneumonia with fluid with pleural effusion. Normal lung, A lines and B lines. Abnormal hypoechoic lung tissue with air bronchogram surrounded by normal lung tissue. Air bronchogram, coarse, horizontal, non-parallel, hyperechoic, contrast with hypoechoic lung tissue. More severe, blood vessels appear live, but there is no blood vessels. Hepatization of the lung tissue. Abscess, the difference is less air bronchogram within the hypoechoic air bronchoechoic area, some kind of encapsulation of the disease area. We can see very small amount of lesions on the ultrasounds. You can see here there is a hypoechoic area with no air bronchogram inside. Looks like abscess, looks like micro-abscess, very small, 1 millimeter. When there is collapse and ATELECTASIS, you can see disappearance of the hypoechoic lung tissue, where you can see around it there is pleural effusion, black area, and you can see here some collapse, and you can see here some hyperechoic air bronchogram. So there is infection here with pleural effusion. These are signs of collapse because there is no hypoechoic area and there is no hyperechoic air bronchogram. This is kind of grading of the lung problem. You can see here is A lines, there's some B lines with more grade 1 diseased lung. You can see disappearance of decreased number of A line and increased number of B lines, and they start to reach to the end of the picture. Total absence of A lines, coalescence of B lines, and start the appearance of hyperechoic subpleural area with air bronchogram. More air bronchogram and become in different direction, increase in thickness and become more hyperechoic, and totally absence of A lines and coalescence of B lines in the grade 4. The limitation of ultrasound in diagnosis of respiratory problem is difficult to differentiate between sometimes between pneumonia and ATELECTASIS from pulmonary hemorrhage, because it all appear as fluid, severe, and the air bronchogram all coalesce to each other. They become like collapse. So you won't able to differentiate collapse from pneumonia from sometimes even abscess. In bronchiolitis, the difference is not bad because it's a thickening of the wall of the bronchi, so they start to see some lung changes, and it can be scored. So with score 0, you will see normal sliding pleura, and you'll see some A lines, and they will be decreased or start to appearance of B lines. With more severe, the A line become diffuse, become dishomogeneous, and they become confluent, and they will see multiple B lines, and the B lines start to reach to the end of the picture, but they are still separated. When the B lines become diffused and become none, and the air bronchogram become dishomogeneous, and there will be subpleural increased echogenicity, consolidation, they become grade 2. Even when we do paravertebral or posterior data, there is grading. So we can grade the bronchiolitis depend on the ultrasound. You can see here different grading of lung ultrasound in bronchiolitis patient. You can see there is here some A line, and you can see that the B lines does not reach to the end of the picture. While here you start to see some consolidation, the B lines start to increase and reach to the end of the picture. The A lines start to be less in number, and there is increased echogenicity of the subpleural area. Subpleural effusion, increased B lines, less A lines. You can see here there are still some A lines, B line is not severe, and there is subpleural consolidation. Asthma can also be diagnosed. The difference is it's because of air trapping. Of course, if it's chronic or not chronic, but in acute one, and there is no chronic changes, there will be air bronchogram. But this air bronchogram is due to trapping of the air, and therefore they will be dynamic. And in addition, if you give bronchodilators, you will see these changes decrease in their number. But also you can see the complications that happen with asthma, like pneumonia, pneumothorax, atelectasis, and chronic lung changes, as discussed in the previous sessions. And here I conclude the third and last session of the lung ultrasound about RDS, TTN, and other respiratory problems. I hope to see you in another call and other questions. Do not hesitate to contact me. Thank you very much and have a good day.